Thanks to Mark and to John for the invitation. So everything I want to say about managing the short neck in 13 minutes, I guess. No disclosures. I'm going to talk a little bit about the data. I'm going to talk a little bit about factors to contribute to complexity, specific devices and adjuncts that are available. A couple words on suprarenal fixation. What's important, I think, is comfort level of the operators in dealing with this problem, and what's coming for the future. I think that this area will continue to be important despite all of the new technology that's coming that's dealing with stuff in the visceral segment, most of the aneurysms that we're continuing to treat, which is going to be with infrarenal devices. So just like everything else, I think we've been working outside the IFU for everything that we do. Devices come out, and then essentially, we look at the IFUs and then we try to extend it. I think that there was some trepidation with this a few years ago. This publication by Andres Schanzer that came out that talked about how compliance with the EVAS guidelines is quite low. Despite our treatments, the aneurysms continue to enlarge, and there's a long-term risk of rupture. I think this was echoed after this publication came out by Roy Greenberg, and it gave at least some of us a little bit of a pause in terms of where we're going and what we're doing. So I think this was a very important publication. Within that, and the reason that I wanted to show this particular slide is that despite the gamut of different devices that are out there, if you look across for the most part, when you look at managing a short neck, the indications for neck length and angulation are about the same, except for a couple of new devices that have come out in the most recent times, about 15 millimeters, 10 millimeter for one of the devices for the neck length, and 60 degrees for angulation. So this is what we have to work with for infrarenal devices. Some of the contributing factors to neck complexity include the length, thrombus burden, angulation, calcification, and then really it's a combination of factors that makes it hard. I think we can all deal with one of these at a time, but certainly it's when we have multiple of these factors that things get a little bit dicey. I think you have to be comfortable and you have to know what the devices are out there and what their specific features are for each one of them. Gore has the new Repositionable device, and that has some advantages. There are some that probably believe a little bit more on suprarenal fixation. The newer devices, like Endologics, although not as new, have a different type of fabric that perhaps gives a different quality in terms of treating some patients. And the new devices with a new angulation indication and a shorter neck requirement for trivascular, which we'll talk about. Nelix, which not ready for use, still in trials, is probably going to be completely different in the way that it behaves, and we'll see how that goes. Here's a particular case with a Gore device. There's a shorter left or lower left renal artery that we're trying to keep, and then essentially what happens when we deploy the device, we cover it, and then you use the feature of the device, which is basically you're able to reconstrain the device and salvage that left renal artery. So in this case, this is a very good adjunct. It's something that has become quite useful for dealing with short necks, the repositionable aspect of the Gore device. There's a completion angiogram, and here's the final view of this. So this particular feature makes this device quite interesting. Here's another case, for example, of another patient that has a very angulated neck. Essentially, this is, again, using the Gore device and the repositionable aspect of it, and also deals a little bit with the angulation. This is clearly outside the IFU for the angulation for this particular device. And you can see that we can place the device where we want it and maybe pull it back a little bit, and then we get an excellent result. So knowing your devices and being able to use what the features are that makes them special, I think it's very important. Some people have done some modifications or have specific techniques that are related to those devices. This is a particular technique in which the orientation of the limb of the graft allows you to be able to deal with neck angulation. I think this is probably, although interesting, it's probably going to go away because there's going to be a new conformable device that's going to come out with Gore that's going to allow you to treat this a little more conventionally. Another particular technique is this kill technique, where you put a cuff in a to extend the seal zone, again allowing you to treat a more complex neck with a normal infrarenal device. This particular technique of bending the wire is also something that people use. It can be used with multiple devices. Again, there's multiple of these techniques and multiple reports. I think it's important to know them, and people have used them to be able to deal with specific problems when they're dealing with the neck. In this case, we treat multiple patients that have an angulation with this particular technique. When we talk about a different stent graft, we're talking about the endurance stent graft. This is different, that has suprarenal fixation, but people have been able to look at the data. This is data from the EVAS Registry, which contains about 925 patients. This is real-world data. It's 104 patients with challenging necks based on length and angulation criteria. This is the distribution of those patients with neck lengths between 10 and 15 millimeters, angulation greater than 60, and calcium in the thrombus in the neck. And you can see that despite those negative features, you're able to treat these patients effectively with low rates of type 1A endoleaks or other problems. So then for those people that like the suprarenal fixation might say, why don't we treat all of the patients with suprarenal fixation? This particular report came out from Pittsburgh comparing patients that had suprarenal fixation to those that have no suprarenal fixation. They have a very large experience of over 1,400 EVARs, and when they were able to compare these two types of graft, they found no difference in migration and endoleak rate between patients that have infrarenal fixation and suprarenal fixation. Endologics gives you other types of advantage. There's an area of traditional seal, if you believe in this issue of the strata and the billowing effect. Allows you to treat certain different types of patients. Patients perhaps that have excessive thrombus in the neck. I think it's a good graft for that. We've had very good results treating these patients. My personal preference for doing these cases with chimneys probably is with this particular graft because of the way that the fabric behaves. This particular patient has a short neck and is a very sick patient with an ejection fraction of 15%. This is the deployment of the device at the bifurcation, then cannulation of the renals bilaterally, then taking the picture of the aorta from the side, and then here's the final angiogram with a nice completion. So there's a large experience with chimney grafts. You can do it in multiple different configurations. The results might be comparable to those with fenestrations. That's probably a topic that's more extensive, can be more extensively discussed at another time. Again, there's an increase in this active seal area. This is a report from Aptus in San Antonio that talks about being able to increase the active seal for these patients using the Endologics device by about 5 millimeters because of the billowing effect of the strata. Trivascular is another one of these grafts that has come out with particular indications. It came out with a indication that touted no neck length restrictions for it. I don't quite understand it because when I read about it and when I have seen it, you still have to have at 13 millimeters a neck that's less than 31 millimeters. So if I have a neck that's 31 millimeters or 13 millimeters, to me, you could probably treat that with multiple devices. So not quite what you read, but there are people that are using it successfully. I personally don't have a lot of experience with this particular graft. A couple of things about some adjuncts. The Endoanchor system, I think, has added a lot to the armamentarium in terms of dealing with short necks. Other than touting the issue of being able to add strength to the fixation, almost to the point where it feels like it's a hand-sewn anastomosis, and this is data from cadavers that shows the increase in strength added by the anchors. There's a large body of literature out there that shows that these are effective not only for treating patients with type 1 endoleaks, but also for treating patients that have very short necks. Nelix, although it hasn't come out, I think it's going to be very exciting because I think this has the potential to change this particular market. There's a EVAS Registry. This is Matt Thompson has a very large experience working with this particular graft. I like to reserve what I think is going to be the results until we get our hands on it and we can use it extensively here in this country. But they do have an EVAS registry that touts the treatment of multiple patients with very short necks with what they feel are excellent results. Wrapping up a little bit, I can tell you what my message is going to be, and that is for this particular topic, this is a study from Italy that talks about dealing with short necks, and you can see the bars in the back are essentially patients that have more than 2 parameters that make it a complex neck, either a short neck plus angulation or short neck plus calcium. And really, when you start to get into problems, when you start having combinations of issues with the short neck, a short neck plus thrombus or a short neck plus angulation, that's what makes things difficult. I think we can all deal with one of those aspects, but once you start combining these different parameters is when you start to get into the issues of type 1 endoleaks. So in closing, I think what we're going to see in the future is probably more widespread use of fenestrated devices for patients that have short necks. I think that's what's going to happen. I think as people get more comfortable with it, even for patients that may have 5 or 7 millimeters with an infrarenal neck, people are going to probably opt to go a little bit higher in their treatment of aortic disease. We'll see what EVAS and branch technology bring to that. Getting to healthier aorta is probably what's going to happen in the future. In the meantime, I think what you have to do is you have to do what you're comfortable doing. I think that's probably the most important thing. If you're comfortable with a particular device, despite the fact that different devices may add different things, I think the most important thing for you as an interventionalist is to do what you're comfortable. Get comfortable with newer devices and uncomplicated anatomy before you try the tough ones. Otherwise, things can go very wrong. And expand your armamentarium. Thank you for your attention.